We have our afternoon panel, so if I can ask the afternoon speakers to come up and have a seat. Our moderator is Dr. J.T. Eckner. He is an associate professor of physical medicine and rehab here at the University of Michigan. He's also the research director for Michigan Neurosport and the research core director for the Michigan Concussion Center. Dr. Eckner.
Thank you, Steve, and thank you to our panelists who are coming up. Thank you. I'd also like to remind those viewing the summit from home on the internet that if you have questions, you can send them to the designated email, which is umconcussion@umich.edu, and a staff member will bring them up to be read. Before I have a chance to look at the questions that are rolling in, I'm going to start off with a question of my own. And given that my own background is in physical medicine and rehab, I'm going to go ahead and ask about concussion rehabilitation. I agree with the idea that exercise is medicine, and one thing that I was a little bit surprised about from this morning was the results from the Big Ten Ivy study that showed that most athletes are not resuming any activity, any physical activity and exercise prior to symptom resolution. I'd like to hear from the panelists how you guys are approaching return to exercise after concussion, how you're deciding when to begin, how much to do, what to track, and how to progress.
Is this working? Hello? Okay. Well, I'm going to speak just from the military context. So we developed a progressive return to activity guidance that was published in 2014 that recommends 24 hours of rest and then resumption of daily activities, and it's a progression, it's kind of a 6-stage progression similar to what you see in Berlin, but trying to be a little bit more specific about different types of exercise so that the progression towards activity and exercise, which, anyone who's in the military, they're very chronic exercisers. They have to run with their unit every day. And so it actually gets them back into aerobic activity if they have stable, relatively low-level symptoms within the first week after their injury. So, and we've done a study looking at the use of the progressive return to activity guidance at providers and their patients, where actually that earlier exercise does seem to result in kind of faster return to normal activity.
Yeah, I pretty much do the same thing. I mean, I'm seeing mostly athletes, and I don't see them on day one. It's mostly within a week or so. So I have them do sub-threshold exercise, kind of like the leady stuff. And I think part of it, the effect is physiological, part of it's also psychological. I think for an athlete to tell them, your time sitting on the couch is over, like I need you to do what you're used to doing, which is be an athlete, their face usually lights up, like, oh, okay, great. And I get like buy-in from them, like, oh, now I'm gonna listen to this guy. So it works on a couple of levels. And I think doing it sub-threshold, like if you get a headache, back off kind of thing seems to be safe.
I don't see patients, as my kids say. I'm just a teacher, doctor, and I'm an athletic trainer, but I don't not a clinician anymore. So I concur with my my panel members up here.
All right, great. This is kind of a prevention question, I guess. Are you concerned about an arms race, quote unquote, in protective equipment?
Yeah, I mean the current arms race and protective equipment that is happening. You need to think about how much money is being spent on head impact monitoring, helmets that can't prevent concussions. I mean, they help, certainly help, but it can't prevent entirely. These head impact systems. We're talking about thousands upon thousands of dollars that parents are putting up, booster clubs are putting up, to buy. It's great that helmets are getting better, and we think about the work that Virginia Tech has done and what that has kind of disrupted the industry to the extent that now we have all these 5-star helmets, and that's great. But then that innovation and all of that energy goes to ultimately these companies need to cover the overhead. And so helmets that are costing $1,000 or more, or $1,500 for a helmet, and parents are putting up that money, or communities are, and where are the schools getting that kind of money from taxes, local taxes? So yeah, it's a concern, and I think that it's hard to steer away from that because it's a physical, tangible thing that someone can see and hold in their hands, and so yeah, whether it's these helmet kinds of add-ons, if it makes like logical, intuitive sense, then it gets momentum, and it is a concern because in some instances it's kind of perpetuating the problem, but then it's draining a lot of funds away as well. So.
All right. A lot of what's rolling in actually are legal questions and CTE questions, so I will maybe spare you guys those. But I'll throw out another biomarker question. A lot of what you talked about during the biomarker talk had to do with identifying and diagnosing concussion. Could you maybe speak to what is coming in the future as far as using biomarkers prognostically, as well as using them to help identify recovery after concussion?
Yeah, I think that's a really important point, JT, and there's a big effort to try to use biomarkers to predict return to play and recovery, and in a sense, it's an easier task than trying to use it to diagnose concussion, because we just kind of need to know if you have a marker above a certain value, what's the chances that this person's going to be able to return to play in a week, and so not too bad of an issue. The problem is that most of the time people are looking at these markers not right at the time of injury, but a day or two or 3 or 4 later, and not all the markers are elevated at that time point. Most of them are come and gone by them, but there are 1 or 2, like neurofilament light chain, that stays up for a long time. So I think that there's hope for that to be useful, maybe in a clinic setting, to figure out, is this person going to be a week, 2 weeks, or a month?
Can I add? I'll just add a little bit related to, I know when people hear biomarker, they think blood biomarkers, but I think they're performance-based biomarkers that a lot of people are looking at as a way to try and get a better sense of someone's capacity. So like in our military work, trying to, not just look at a single variable by itself, so just balance by itself. I mean, because there's evidence that, there's this issue of dual test performance that may be a residual problem for people post-concussion, that if you look at cognition by itself and you look at balance by itself, those both look fine. But when you combine those two things at the same time, you see differences in people that are recovering from concussion versus their healthy control counterparts. So I think a lot of people are working to try and come up with something that is really clinically feasible, and that's been our focus with our collaborators at Fort Bragg. But it's hard because you have to have performance-based comparisons and a control group that makes sense. So we have, in some of the accelerometry data that we're using, which is a biomarker, it depends on if we get somebody who is big Army, kind of regular enlisted person in the Army that has had a concussion. You can see this impairment that's really clear compared to their healthy control counterparts. You get a special forces guy that's had a concussion. He looks like the healthy control counterparts from Big Army because he's operating at a more elite level. So we've got to have a comparison group of those special forces people in order to interpret that data. Then that's going to require sort of understanding, is similar to what you were talking about with the DTI thing, like what is normal. And that's hard work to do because it takes a lot of time and effort. But I think it's, in TBI rehab, you always kind of have this idea of, okay, what does this person need to be able to do in their life? And you're going to try and simulate that in some way and see if they can do it successfully. So it's that sort of mindset of life things that we do are complex, and you're not just standing still, you're moving, you're thinking about something, so your simulation of actual athletic activities and remembering plays while they're, doing drills and that sort of thing I think those kinds of things have potential to really be useful in making some of those decisions to return to play, return to duty, return to work, return to learn, all of that.
All right. The point was made that often some of the primary barriers to returning to work, returning to sport, and returning to school are psychological in nature. And so the question then is, why not have earlier involvement of mental health professionals, psychologists, psychiatrists, earlier on in the process of recovery, not just waiting until there is a prolonged recovery before getting them involved?
Yeah, I think that's what many people are doing. And when I say many, I mean me, pretty much. I think we screen for anxiety and depression on the first visit, and we're lucky in Rochester. The clinic is in child neurology, and we have 2 therapists there. So if they screen high on one of those, either anxiety or depression, we kind of get them involved right from the start. I think it makes a lot of sense. Do we have evidence to back it up? No. Not yet, but it seems to be, the right thing to do. I think that's because that is often the thing that prevents recovery. It's the unrecognized anxiety, unrecognized depression that then gets worse when people aren't getting better.
I think there's a challenge with some of the folks that we might be dealing with, though, with stigma around admitting that they might need assistance related to mental health. So I certainly see that with our military population, where sometimes it may not be anxiety as much as depression or post-traumatic stress, where, admitting that you need help for that sometimes is something that is inconsistent with the view they have of themselves as, being Army strong or whatever. So I think that is an additional barrier that isn't necessarily imposed by the system, but more by the individuals that have had the injury. So, trying to make it so people are more open to that as a possibility that it could help is, I think that's a big challenge.
I'm going to ask another.
I concur.
Sorry,
I
go
concur.
Ahead.
I agree. Okay. Totally support what you said.
I'm going to go ahead and ask another biomarker-related question. During your talk, Jeff, you mentioned some of the DTI findings in athletes who have played a contact sport like football but not had a clinically diagnosed concussion. And you mainly talked about them as if they were kind of a false positive. I wonder, do you have any thoughts about whether they may represent potential subclinical injury that we should be giving more thought to or be more concerned about?
Oh, geez. If that's the impression I gave, that's not what I was trying to convey. I was trying to convey that it probably is a true positive, and that the idea of when you start looking at the brain on that kind of a level, you kind of the idea of there being a difference between a clinically diagnosed concussion and one not seems to be, superficial, artificial, moot. So that really there's probably a spectrum of injury, and some of it rises to the point of where you have symptoms, and sometimes it doesn't. That's exactly the opposite of what I was trying to say. So I'm glad you brought it up. I'm glad you brought it up. I was trying to say this is likely real, because we're seeing it with blood biomarkers as well as with imaging. But we don't. So I didn't want to spend too much time talking about it because this is a concussion summit, and I didn't want to say what does concussion mean? To throw the whole thing into a tailspin, but that kind of does raise that point. Yeah. Thanks for allowing me to correct myself.
Maybe it was just me. The next question will be for our experts who see patients, and it relates to CTE, but I think that for you guys, you probably get these questions. So with the ongoing research and the evolving understanding of CTE, how do you address questions whenever patients and their parents are asking you about what their concussion means for their risk of CTE, or what their head impact exposure means for their risk of CTE? What is your approach to those questions in clinic?
Okay, I get asked this question literally every day in clinic. So I kind of tell them this is a risk-benefit question. So there's a benefit to the sport, and there's a risk to the sport. The benefit to the sport is going to differ from patient to patient. For some people, it's the potential benefit is high. Like it's the only way they're going to get to college, or it's the only way they're going to get out of a bad home, social situation or home life. So for other people, it's a little less clear what the benefit is. But I try to get them to think about, okay, what's the benefit? Now, what's the other side of the equation? That's a little harder. And I kind of tell them, like, we don't have a whole lot of evidence that links, multiple concussions to CTE. The risk is probably greater than zero, but how much greater than zero, I don't know. And so I have to kind of tell them that. I tell them the evidence that's out there, and it's kind of murky, and I try to get a sense for them what their tolerance for risk is. So there's no clear answer for this because we don't have the evidence. So if they have a high tolerance for risk and it looks like the benefit of the sport is high, then I say, okay, we'll do an MRI, we'll do it now, we'll do it again in a year, we'll try to do everything we can to make sure your brain's not shrinking. But if their tolerance for risk is low, then I say the only way to prevent a possible problem with early onset dementia is to stop now. So it's not really based so much on evidence as it is on understanding their values, what their value is, how they value the sport, and what their tolerance for risk is. How is that for like a nebulous psychosocial? But that's what I do, because there's no guideline, there's nothing out there to really guide this.
I'll say I use a similar nebulous approach when my patients ask me the same question.
Okay.
So this is kind of a legal question, but it's also kind of getting at unintended consequences, which we talked a little bit about in the prevention discussion. And it also relates to biomarkers a little bit. As technology advances and we're developing new tests for concussion, do you foresee a scenario where we might develop a test that is very good at the point of care and become standard of care? And if so, do you envision that could be potentially cost prohibitive to some sports teams or organizations and potentially have an unintended consequence of increasing liability to the point that they can't promote the sport?
Wow, that's like, who wrote that question? That's such a doomsday scenario. Who came up with that? I mean, I suppose. I suppose that's possible. But I think we also have that problem with helmets right now. They're super expensive. I don't know that every city school kid in Rochester can afford a $150 helmet. So there's definitely an economic problem in general. And you're right. Whoever asked that question I guess it is possible, unless insurers got behind it and we had a different healthcare system in this country. But I think that the upside, the cost savings would be high. If someone did an economic analysis, they might find that the money you invest, you get back on the other end from avoidable injuries and unnecessary ED visits and things like that.
That would be really logical.
So you're saying I have no role in government, basically.
Exactly.
Okay.
And you can be glad about that. Yeah.
All right, I'm going to go ahead and wrap it up with that one. Thanks to our speakers for a great panel, and I'll invite Dr. Braulio back up to the podium to deliver closing remarks.
All right, thank you, JT. Thank you to our panelists. Thank you to everyone in the room for coming and who stayed until the end. I just want to remind everyone that you'll be receiving an electronic evaluation form soon from our team. Please take the time to fill it out and give honest feedback. We're already starting to think ahead 3 or 4 years for the next one. We want to deliver the content that you want to receive. So please tell us what worked well today, what didn't work well today, maybe some things you liked or things you'd like to see in the future, because we're very open to it. If you have time, we're going to do a tour of the stadium. We'll congregate out here in the atrium, and you can get a quick behind-the-scenes look as soon as we wrap up here. I want to give a couple of thank yous. Rick Bancroft in the back from Department of Athletics was huge in helping us coordinate everything today, so thank you, Rick. We appreciate your help there. Bethany Pollock. I don't see Bethany Pollock or Jessica. Oh, there you are, over there. So Bethany Pollock did it all. And I'm actually being very serious about that. So anything good that happened today, that was Bethany. Anything bad that happened today, I had a hand in that. So thank you to Bethany. And then Jessica Roche is floating around somewhere. I'm not sure where she is. Also from the Injury Center. So thank you, Jessica, stuck her head in the door just to receive applause today. So thank you, Jessica. From the Concussion Center, Carrie Morton, who's hiding up here in the front, so is our deputy director, who has been instrumental in helping us out, along with Nicole LaRue, who helps us keep the lights on and make sure we keep me moving forward is really what that's all about. So thank you to you guys and the rest of the staff that made today possible. If you are heading straight out, please travel safely. We want to see you back in a few years. So thank you, everyone. We enjoyed your time today.